Uh, Hi, everybody. Uh, on September 9, 2024, a 50-year-old man from Mexico with no prior medical history come to the hospital and referred decreased vision in both eyes. At the first evaluation, visual acuity was 20/90 in both eyes, IOP with normal limits, depth anterior chamber, and subcapsular cataract in both eyes. In the fundus, we found subcapsular cataract in both eyes. In the fundus, we found, applied retina, macula with good foveal brightness, optic nerve cup disc 0.3 in both eyes, and we recommend PHACO surgery. The PHACO surgery of the right eye was on October 10 and the left eye on 1 day later. The first post-operative assessment showed visual acuity 20/40 vision in both eyes. The following meds were prescribed was moxifloxacin 5 times daily for 10 days, steroid every 4 hours for a week, then tapering, and bromfenac every 12 hours. The next appointment was scheduled for 1 month later. 1 month after surgery, on November 3rd, vision acuity was 20/20 in both eyes. The next appointment was recommended in 6 months, but the patient returned early on April 2025, referring decreased vision for approximately 10 days in the left eye. He didn't refer to systemic symptoms such as headache, nausea, and vomiting. The visual acuity was decreased in the left eye, pointing fingers at 2 meters. IOP was in normal limits in both eyes and relieved afferent pupillary defect in the left eye. Intraocular lens in the capsular bag in both eyes. No change were observed in the fundus of the right eye. However, the left eye showed applied retinal vascular tortuosity, increased bright foveal macula, and blurred optic nerve borders. What would it be? We made a macular OCT. The macular OCT revealed intraretinal edema from temporal peripapillary area to nasal parafoveal area. We sent laboratory tests including HB, PDRL, and TORCH. We think that is neuroretinized. We prescribed doxycycline 100 milligrams twice a day until new ophthalmological evaluation. A month later, the patient came to a new evaluation. Visual acuity was counting fingers at 2 meters. The IOP in normal limits in the fundus macular exudates appear and blurred optic nerve borders. WGR test abnormal in the left eye and antler grill distortion in the left eye. In visual fields, the right eye unreliable study due to 19% false negatives with a right central scotoma that respect the midline. In the left eye, underlabel study due to 40% false negatives, right hemianopsia that does not respect the male line. The macular OCT of the left eye showed exudates involving the macula, shaped like a star because they are located in the outer outer plexiform layer. The results of laboratory studies only showed herpes type 2 positive. For this reason, oral antiviral treatment was started. Acyclovir 400 milligrams 5 times a day. It was recommended that a return visit be made in a week for further evaluation. All patients present decreased visual acuity and papillitis at onset with subsequent macular start developing. After a few weeks are presented. The picture A shows the fundus after 10 days visual loss. The optic nerve show length and there aren't exudates. And picture B is the same patient, 1 month, the optic nerve head edema was spontaneous improved and a macular start is developing. In picture C, the last evaluation, we can appreciate macular start. The macular OCT of the left eye revealed intraretinal edema from the temporal peripapillary area to the nasal area and parafoveal to parafoveal area. The picture B and C reported macular edema, and the next evaluation will be on 2 weeks. Neuroretinitis, it was originally described by Leiber in 1960 as a stealth maculopathy, but this definition was changed by Glass in 1977. Citing that this edema presets macular exudatives, subsequently, Glass confirmed optic disc leakage by fluorescein angiography and subsequent the term neuroretinitis. Neuroretinitis is characterized by an inflammation of the optic disc vasculature with exudation of fluid into the peripapillary retina. The lipid-rich component of the exudative is further able to penetrate into the outer plexiform layer, creating that its clinical seems as macular star pattern. The etiology of neuroretinitis can divide into 3 categories: infection, non-infection, and idiopathic. Among the cause of infection, neuroretinitis, a cat scratch disease can caused by Bartonella Hensel has considered be showing to be the most common. Other infection causes, including involving a wide range of organisms such as virus, fungi, and parasites. No infection neuroretinitis may be caused by underlying systemic inflammatory disease such as sarcoidosis. The diagnosis of idiopathic neuroretinitis should be considered in case in where infection and non-infection cause can be identified. Clinical neuroretinitis is classically defined as a clinical trial of unilateral painless vision loss accompanied by optic disc edema and characteristic macular star formation. However, the clinical you can see in this picture. Most patients will neuroretinitis present with painless unilateral vision loss, but occasionally can have bilateral spontaneous or sequential involvement. The latest medical history should include several travel, animals exposure, skin change, lipid node enlargement, and systemic symptoms. Other studies, such as color vision test using Shara plates, identify dyschromatopsia. Optic coherence tomograph, you can identify inflammation of the optic disc vasculature with exudation of fluid into the peripapillary retina. Fluorescein angiography should show what leakage at the disc with no evidence of retinal vasculitis or late staining of the venous walls. And in visual field is most commonly identified central scotoma or central scotoma. Brain and orbital magnetic resonance, which were performed to confirm the presence of abscess of optic nerve disease, such as optic neuritis and papilledema. And systemic laboratory are important to identify that is an infection or no infection etiology. It is not uncommon for musculars to be mistakes for the neuroretinitis. Newly diagnosed malignant hypertension was the most common masquerader, 42%, broad retinal venous occlusion, 21%, idiopathic intraretinal hypertension, 40%, diabetic papillopathy, 40%, and anterior ischemic optic neuropathy, 7%. Idiopathic intracranial hypertension is the one of the conditions that we need to differentiate along with malignant hypertension in neuroretinitis. When we see a patient with suspect neuroretinitis, it's important to rule out idiopathic intracranial hypertension by checking for neurologic symptoms, including headache, nausea, vomiting, visual disturbance such as diplopia, translate visual loss, blurred vision, and hearing impairment, which are common in idiopathic intracranial hypertension. Depending of the cause, the treatment includes steroids, antibiotics, or combination therapy. After excluding an infection etiology, idiopathic neuroretinitis is treatment with steroids during the acute episode. If the patient is not at risk for recurrent idiopathic neuroretinitis, intravitreal steroid injection are oral or intravenous steroids and immunosuppressors agents may be considered for a long-term prophylaxis. When neuroretinitis is caused for Bartonella doxycycline, it's a good option for 4 to 6 weeks. When it's caused by syphilis, crystalline with penicillin, it's a good option. In our case, herpes was the etiology of our case, but I found that agamciclovir is a good option intravenous or intraretinal to treat this case. In the clinical trial conclusion, the clinical trial might not always be present in its internet, especially in the early stage. Treatment and prognostic vary depending on the cause, and it's important to distinguish between infection and non-infection etiologies, mostly inflammatory and idiopathic disorders. The routine use of systemic corticoids in infection neuroretinitis is not recommended, and target antimicrobial agents should be instituted in case of neuroretinitis due to a specific infection etiology. Thank you.
Ana Paula, that's a great case. That's really interesting. Do you think there was any relationship with the cataract surgery or no?
I don't think that I don't think that the PHACO surgery is related with this situation. I think that the patient has some stress, or I don't I think that the stress of the patient can immunosuppress the patient, and maybe the herpes can start this neuroretinitis.
Yeah.
And I think that is an incredible case because the patient has a visual acuity 20/20, but as it's a surprise that 6 months later, the visual acuity lower.
And sorry, the treatment was with valacyclovir or?
No, was with acyclovir, 4 milligrams, 5 times daily, and I see the second time with Dr. Isa, and Dr. Isa recommend to start this treatment, and then I see a week later, and I evaluate the visual acuity, and the visual acuity improved 20 over 40 100. Here, you can here.
Mm.
Now
And
the new evaluation will be in 2 weeks.
okay. So hopefully continued improvement. And
Yes, I think that.
you're continuing the same dose of acyclovir.
Yes, he continued the the acyclovir.
So I agree. It was just a really interesting case. Usually with any inflammation and viral infections, we tend to think that it should be quiet before we go in, but in this case, it was very quiet, and there was no signs of anything. So, it is a rare case, I think, and I think it's being well handled, well managed. Let's hope there is um a better visual outcome. I hope so. Yeah. Amy, do you have a comment?
Hi. Yeah, I just had a question. So a great presentation. Thank you so much. Are we thinking this is a primary HSV manifestation or a recurrence of HSV?
It's the it's the first Dr. Ahmed, I don't understand. Can you repeat, please?
Sure. Okay. So in with HSV infection, usually we have the primary infection, and then that kind of clears, but the virus goes dormant in the body, and then it can come out at any time after that. I was just wondering if you had asked him, since it's HSV2, if you had asked him, had he had any incidents of genital ulcers or oral ulcers, just so that we could understand, is this a recurrence or is it a primary infection? Because what I'm getting at is, if we think he just had this, it's a sexually transmitted disease, it would probably be maybe good to consider to ask him about other. Oh, so his IgG was positive and his IgM.
Yes, Dr. Ahmed, the patient did earpiece labs. We sent laboratory studies that include earpiece and earpiece type 2, HM and HGG was positive. And I think
Okay.
not that is not the first infection.
Okay, got it. I missed that. So I think a good point is just when patients come in with these possibly sexually transmitted infections. In his case, it could have been just a recurrent one, but I always make sure to tell them that, and make sure they don't have any other symptoms of syphilis, gonorrhea, chlamydia, any of those other things. So just something to think about for his just systemic health.
Okay.
I'm sorry, I'm sort of in the middle of traffic. If there is no more comments, or if there is anybody else want to comment anything, I'm kind of driving, so go ahead, comment. I'm going to turn my audio off. So
Dr. Ahmed, the patient don't have any lesion in her face. He don't have I don't know, I don't know to see ulcers or skin lesions by herpes. The patient don't have this. And I think that is a secondary infection because the patient have the have um, have these values positive.
Well, keep us posted on the progress. It'd be I think we're all interested in knowing how he does over the next few weeks. There's a big anatomic improvement in the subretinal fluids. You sort of would have expected, I would have expected maybe a better acuity at this point, but maybe that will come with some more time. And it'd be interesting to know how the, if the APD persists, and if there's any residual RNFL thinning from the disc involvement.
The next evaluation will be in 2 weeks, and we repeat visual fields, evaluate the visual acuity, and we recommend to do another labs to evaluate the improve of the patient.
Oh, I had one more question. So he might be a good candidate to be on prophylactic low dose oral acyclovir for a year or two after this to prevent additional episodes. So that might be something to think about.
Yeah, we usually do that with the patient, Dr. Adele, that we put them on prophylaxis for a long time.
Thank you, Dr. Raime.
Hey, sorry, I'm back. So no more comments. I still think this is a great case. If it's a primary infection, it's still more, still pretty rare, but we should Anna, we should follow this patient. I really want to know what the visual field looks like, and if we have an OCT, that'd be great to have. I don't know if you commented on that, but that'd be great to see that in the future. Please let us know.
Okay.
Okay. Goodbye.
Good night, everyone. Thank you.
Yeah. Thank you, Ana Paula.